One is the sensors that became better, cheaper, and more rugged, that they could be wearable or embedded in the mobile phones. Second was the emergence of mobile smartphones that allowed us to process the acquired sensor data right at the point of collection on our body itself, so that any decisions could be taken in real time based on the data that has just been collected. And so this was the supply side. Then there was the demand side, where the emerging crisis in healthcare because of a shift in focus from treating acute diseases to caring for or management of chronic diseases. So all of this together gave birth to this area of mobile health. And so what it did is that the domain of health equipment, which used to be mostly by the large companies like GE or Medtronic or Siemens now or Philips, the mobile health made it possible for smaller players to emerge and begin the innovation. And now you see various devices by these small companies. So mobile health has presented us with tremendous opportunities and promises. What you see here is a VisiMobile system that is able to measure vital signs in a hospital setting, which they soon plan to take into the real world. You see, there is a well-doc system that is able to help with management of insulin levels for diabetes patient. There is a Philips Lifeline, which uses accelerometry to detect falls and send emergency notification. Then there are fitness devices like the Fuel Band from Nike, which can be used for both assessment or monitoring of physical activity as well as in interventions to encourage physical activity. So if we were to project forward in the future, I understand that progress in health occurs slowly and visibly so, because we need to be extremely careful with what we claim, and what we put out is safe and efficacious. But still, if we were to take a vision, I would say that in a couple of decades, we would envision a ubiquitous healthcare where something we carry or something around us, devices on us, around us, are able to assess our health, environment, lifestyle, behavior on a continuous basis, whether it is our cars, or whether it is our cell phone, or whether it is our smartwatch, or whether it is our home. And so that's the collection of data. And then you may have heard of the IBM Watson that was able to defeat the chess champions in 90s, then able to defeat the quiz champions in the 2000s, and is now being applied to mine the data related to healthcare, and is being currently tried by the insurance companies. And so what I'm trying to say is, when the IBM Big Blue defeated the chess champions in 1990s, now we carry in our pocket a device that can actually defeat us in chess. So which means the intelligence that you see in big bulky machines, it's only a matter of time before they get miniaturized, and that same power is available at our fingertips. So if IBM Watson today is able to mine the data related to health, tomorrow it should be available on our cell phones to do all the analysis. And it should be aware of the latest results that have happened by being able to mine the web and apply those methods to the data that has been collected by the devices on and around us. And so as a result, what we would expect is that the life expectancy should improve, and the lag time that we have right now with respect to health research from the initiation to the publication, from 5 years, I would hope that we can bring it down to a couple of years, if not less. So if we try to break it down into challenges, so if we do envision health systems to be adopted at mass scale, it shouldn't be that we ask people to wear something. So it should be able to pervade and disappear in and around the surroundings. So that means there should not be any burden to acquire data. Today there is. Second is it will be adopted at mass scale only if it is helpful and does something for people which they are not able to do themselves today. And so one of the promising directions is just-in-time intervention. If the system can itself anticipate when somebody needs an intervention or needs a suggestion, for example, to break the urge of a person who is trying to quit smoking, and intervene at that time rather than relying on the person to report, oh, I'm feeling an urge, can you break my urge? The third is that if we take the example of smoking, it's not only, say, stress or alcohol. There are a variety of factors in different situations which could initiate an urge. So the system should not just be able to anticipate the urge, but it should be specific to the person as well as to the situation. So if we can accomplish all this, then we may be able to have a technology that indeed works and can be adopted at mass scale. So our journey in this area started with the Genes, Environment, and Health Initiative at NIH, which called for field deployable tools to assess behavior and context and exposure in the natural field environment so that we could study the interaction between the exposure and the genetics to explain the etiology of complex diseases. Our team was picked to develop a field deployable tool for assessing stress and addictive behaviors. So the room is full of behavioral scientists, so you would understand the difficulty, but I would like to mention it nevertheless. If it is about, say, an arrhythmia of the heart, we have made some great progress, and we can identify the beats or the morphology of the signal and say, no, okay, that beat doesn't look right. But when it comes to human behaviors, we don't have any sensor. We don't have that kind of straightforward method to say, okay, that doesn't look right. So what the best we can do today is acquire data from some sensors, even if it is as simple as physical activity, put some accelerometer on the body at the various places, and then be able to make inferences. Oh, was the person walking? Or were they exercising? Were they jumping? Or were they moving in a motorized vehicle? And so on. So even for a simpler thing as physical activity, we have to make inferences from raw sensor data. And if we move to more complex problems as the stress and various addictive behaviors, it's even more challenging. So not only that, also we have, so when we detect a particular behavior, just saying that this behavior happens isn't enough. What we are indeed interested in is treating, right? Being able to do something about it. That means we want to establish some causality so that we understand the relationship among various behaviors and context, and that might give us enough hooks to be able to do something about it. So it's about being able to detect multiple behaviors on a single platform so that we can study the relationship among them. And that's the problem that we have taken on in our research. So the first task was, this research started in 2007. So the first task was to develop a platform which didn't exist at that time so that we can assess multiple behaviors simultaneously. So what I'm going to describe is a wearable sensor suite that we built called AutoSense, then a mobile phone software that goes with it, and then some small scale studies where we have tried it and thus far it works. Next, I will talk about the automated assessment of several behaviors and situations, and then I'll conclude with something exciting, which is future directions. So the AutoSense consists of a chest band right now, which is the respiratory inductive plethysmography band, and there are several sensors that are embedded in that unit. So this is what it looks like right now. It has ECG, respiration, skin conductance, temperature, and accelerometry. And then there is an armband that has alcohol, GSR, and accelerometer, and recently we actually updated that to being this kind of form factor, which can be worn on the wrist. And that's how the sensor board looks like. That fits into this. This is a nano form factor. So much like the wristwatch that you may also start to see from Apple and from Google or Samsung. So the two sensor suites together can potentially provide us with assessment of a variety of behaviors. All along, our goal in here was to be able to get reliable data out of these sensors and to see if we can reliably infer various human behaviors. So the first task was to make them rugged and reliable so that we can get good quality data from the field. So there are several challenges. The challenges are that of the data you get is not good quality because the attachment of the sensor is not right, or because the data is lost in the wireless channel because it has to be transmitted on a continuous basis. So we have addressed most of those aspects thus far. Another problem is that when we put this wireless antenna close to the human body, it gets dissipated. You lose 30% of the power. And so losing 30% of the data is not good. So we were able to address those as well. So the wireless radios we have, we are able to get good quality data, and I'll show you some numbers of that. Next task was we wanted to then get all of this data on the mobile phone so we can actually process them, make some decisions, potentially to initiate an EMA if we notice something not right. So this mobile phone software is able to collect the data from sensors both on the body as well as on the mobile phone itself, then make some compute features like heart rate variability, and so on, and then make inferences from that of stress, conversation, activity, posture, location, and the quality of the data itself. The mobile phone is also able to prompt the subjects for self-report, and all of that data can get collected on the mobile phone, and every such data is actually time synchronized to each other, so you don't have to align them later on. Just to show some screenshots of the mobile phone software, you can pair the sensors to a particular mobile phone. So conceivably, every person in this room could be wearing this device and have a mobile phone, and each of your data will go to your respective mobile phone without having interference from each other. You can also use this software to conduct lab studies, and you can put the markers when each session is happening, and so then the data, the physiological data that is coming to the mobile phone is timestamped on the phone as well, so you will have time synchronization of when each session began, how the physiology looks like at that time, and so on. And in the field, the same software can be used to initiate self-report, which is which is the last screenshot. As I said, we can conduct a study. If we don't get good data, it's useless, right? So to monitor and improve compliance and the chances that we get good data, we took several steps. So first was allowed both the subject as well as the coordinator to see when they wear the sensor, is the sensor working well or not? And so anybody can press some buttons and be able to see in the live whether the data is being collected or not. They can jerk their hand and see, okay, is my accelerometer working? And is my respiration working? Am I getting good ECG signal? Then the phone displays whether all the sensors are continue to be connected to the mobile phone or not. And also display what they have earned thus far in terms of incentive to keep them motivated. And also their contribution can be reviewed, how much good quality data have they contributed each day thus far. We have done some small scale studies with this, and as you can see some numbers here. We are gradually stepping it up to now going into hundreds and potentially in a year or so, 2,000 as well. To give you some sense of what kind of numbers we get thus far, so we are able to recover most of the losses because the losses are mostly, say, 1/4 of an ECG cycle or 1/4 of a respiration cycle, which can easily be interpolated. And so with that, we lose about less than 1% in the wireless channel. We usually notice that people wear it for about 10 hours, so we get good quality data for about 10 hours a day, and we get about 90% or so response rate on the self-report prompts. So thus far, we have collected about 5,000 hours or more of the data. So with that kind of data collection, the purpose of each of those data collection was actually not just to say whether the technology works or not, but to be able to come up with models so that we can use the same physiological or sensor data to infer some behaviors of interest. So I'm going to talk about 3 behaviors of interest or states of interest. One is a measure of stress, the other is the measure of smoking, the third is the measure of conversation, all from these physiological measurements that we get from autocells. So measure of stress has been kind of a desirable behavior to obtain, but with varying degrees of success. The history goes long back, when people noticed that stress does activate physiology, and so we should be able to look at the physiology and infer whether a person is undergoing stress or not. But the trouble is the same physiology is affected by many other things, not just by stress. So how do we separate out, whether the physiological arousal we are seeing, is it due to stress or is it due to something else? Then each of us are different, as you very well understand, in gender, race, ethnicity, age, and even if all of those factors are same, we still are different in terms of our physiology, in how we react to the same stressor. And then, to top it all, we don't, I guess if we take a poll in this room, I'm not sure if we can agree on what stress is. So it's hard to, say again? Okay, so if I was saying, can you hear me now? Yeah, so, can you hear me now? Yeah, so if we took a poll in this room about stress, we won't be able to agree on a definition. So even if we came up with a measure of stress, I'm not sure if we could get an agreement, oh, you really did get a measure of stress. And that is another issue. So the approach we followed was, so we conducted a lab study, a small-scale lab study with a stress protocol that has been used time and again. Public speaking, mental arithmetic, and a cold pressor. And the same subjects then wore the sensors in the lab, and they also wore the sensor in the field, and we obtained the self-reported rating of their stress level, both in the lab and in the field. And our goal was to come up with identify a fingerprint, if you may call it, on physiological measurements that can identify the physiological arousal that is usually associated with stress. In this case, the data we have is from this lab protocol. So our goal was to say, given the data from this 21 subjects or any subject whatsoever, can the model, if it knows nothing about when the person was undergoing stress or not, can it tell whether a minute of measurement that it sees, did it come from that time when the subject was under a stress protocol or in a rest or otherwise? Okay? So that was the goal. So here is a snapshot of data from one particular subject. This is ECG data. What is plotted is the timing between successive beats of the heart. So this is RTY interval. So lower the RTY interval, higher the heart rate. What you can see is that this is the public speaking part. This is mental arithmetic in seated in a standing position, counterbalanced. And this is the cold pressor. What you can notice is that the heart responds very quickly to each of these stressors. That's one. Second, it recovers very quickly too. So as soon as the stressor is over, the body is back to normal, and that's what we would expect. So the challenges in developing a model to automatically infer stress are numerous, but then there are some practical challenges as well. So what you see is a snapshot of data from the field. So sometimes the signal looks good, and supposedly good, that at least we can identify the R peaks. Then this is what the signal looks like, and then this is another aspect of the signal, and then if it's detached, then it's easy to detect. So we need to be, if we are talking about an automated method that nobody is visualizing and saying, oh, this data is good, this data is not good, we need a system, an algorithm that can automatically identify when the data is good, when the data is not good, so that we are not making wrong decisions. And then there are outliers which we need to filter out. And so once we are able to identify good quality data, remove the outliers and noises, then we can extract the R2R intervals. And once we extract the R2R intervals, we can obtain a variety of measures. So heart rate variability will be just one measure. We also found that 80th percentile or median of R2R intervals are also pretty useful measures from ECG. So ECG, though, has had quite a bit of history. So we know much more about ECG and what kind of problems happen with ECG signals than what we know about respiration. Further, respiration is something we can control too, right? We can hold our breath, we can take deep breaths, and so on. So processing of the respiration data is even more challenging, but it is quite informative if we can manage to process it. So what I'm showing here are snippets of respiration, all on exactly the same axis in terms of time and the amplitude. And these are all the data that we collected just from, say, one subject. So you can see that at various times of the day, the measurements could be different. And what you see, these actually are from a yoga session. So that means when people take deep breaths or quick breaths, the signal looks quite different. So, and similarly, the data could be of varying quality. So we need to be very cognizant when we are dealing with physiological measurements, especially if we're going to collect it in the field, to have a method to be able to identify which data is good, which data is not good, and even if it is good, being able to process it such that we can identify useful information from it. That's one. Second, usually it's our experience that measurements that are about time domain, that means timing between successive beats, or the interval of say, between two successive peaks in the respiration cycle, they are more robust than those that are based on amplitude. And as you can see here, why, right? So if we're just depending on the amplitude here is much higher than here, but the information usually is contained in the timing. Okay. So, so from respiration also we computed a variety of features: inhalation duration, exhalation duration. And another thing we notice is that many times, because we are measuring respiration as the expansion and contraction of the lungs, the lung reaches its contracted state and it can't contract no further. So for example, when we are speaking, we take deep breaths, then talk for some time, the lung contracts, it can't contract any further, but we still keep talking because there is some more air left. When we are completely out of air, then we breathe, take a deep breath again. So the amount of time we spend at the bottom of the respiration cycle is also a useful feature. So we used a variety of these features to see if we can identify a fingerprint. And so for that purpose, we went through several steps. Sorry about some of the slides didn't come as well on this system as it was on my system. So the first was so we wanted a model such that if somebody asks me, can I use your model, it shouldn't require me to say, yes, you can use it, but first you have to do the same stress protocol in the lab that we did so that you can calibrate the system. So then most people are not going to use it. So we wanted a system that can self-calibrate itself to be able to adjust to individual biases. And for that, I think what we found was that it's sufficient to normalize the features when we say heart rate or heart rate variability or respiration rate to each person by computing their mean and standard deviation and then using z-scores of the features rather than absolute values. The other was, for computing a mean and standard deviation, do some Wins-riation so that you are not affected by outliers. So with that, we were able to account for between subject differences. Then to identify the fingerprint, we resorted to machine learning. We used support vector machine to be able to identify the right fingerprint across these features, which is able to project all of these features into a higher dimension to find a linear separation so that when we get measurements from a person, we can take 1 minute of their data, extract the same features, project in the same dimension, and be able to say whether it falls on the yes side or no side of, say, a stress line. Okay? So in this subject pool, we were able to do a cross-subject validation. That means we took the data of few subjects, withheld other subjects for only testing, and be able to see what kind of accuracy do we get if we train on some subjects and test on other subjects. And we repeated that so that we don't have any lucky subjects, meaning we used every combination of, say, 10 subjects for training and the remaining for testing. And so we are thus far satisfied with kind of accuracy we get. This is, again, in the lab data, thus far. So we realized is that in the lab, we could ask people to sit idle, and if they move, we can note it down. But when we let them loose in the field, we have no control over their physical activity, right? And physical activity can act as a very big confounder. So we need some way to be able to tell the physiological arousal that we are seeing right now probably is not due to stress and is due to something else. And something else is, in most cases, physical activity. So we had to have a way to understand when the activity is too intense. And for that, we use the walking to say if the person is walking, then we can't assess the stress for now. Later on, we should probably improve and come up with a method to extract the physiological arousal that is in addition to that will be demanded by physical activity, but that's subject of future work. So for now, we have a threshold And if the physical activity is more than that threshold, then we say we can't assess for a stress or physiological arousal for a stress at that time. And that's about 20% of the time in the field setting. Okay. So next was, this model was trained in the lab. And how do we know that it does capture physiological arousal due to stress in the field? And so for that, we wanted to validate it with self-report. So, and this is tricky. And validation with self-report is what many people have tried before. And so our approach was slightly different. What we realized is that the initiation or activation and recovery of physiology due to a stressor and our perception of a stress which will produce on self-report occur on a different time scale. So for instance, if there was a traffic scare, our physiology will rise sharply and it will come back to normal in, say, 2 minutes or 5 minutes. But if you ask me, 15 minutes later, I would still say I'm pretty stressed. So, so we can't, so if suppose we ask somebody to self-report their rating of stress now, we can't go back and say, oh, they said they are stressed right now because just 2 minutes ago they were stressed, or maybe they were stressed 5 minutes ago, or maybe the stressor occurred 10 minutes ago. So you can't just use data preceding the self-report to say this is what corresponds to the rating they provided. And we can't, if you average them out, you're losing the information. So what we came up with was we decoupled them to have their own time scales for activation and deactivation. Ultimately, we came up with an autoregressive model that has two components. One is is if suppose somebody had a stressor at some point in time, and then their perception of being stressed will decrease over time if there is no other stressor. And that's the factor alpha. And the other factor is that if a stressor occurs, then the perception of stress will keep increasing, and that's the accumulation factor beta. And both of these factors are going to be person-dependent, and which we estimate from the self-report itself. So the input to this model is whether our physiological model says the person is currently stressed or not stressed, which is just a binary value right now. So we applied this model to the self-report data we got from the lab as well as from the field. So in the lab, we asked every subject to report their stress rating 14 times. And then the same subjects wore the sensors in the field, and they gave self-reported rating of stress about 20 times each day. So in the lab, which is on the left side, which is on the right side, what you see are the correlation for each subject. So for each subject, we found a correlation between their 14 self-reported rating and what our model predicted to happen at those 14 time instances. And so we find a median correlation of about 0.72. And then in the field, we looked at the rating they provided across 2 days. We pooled them together. So for each subject, we have only one rating. And then we also pooled the rating given by our model and then tried to see what correlation do we get for each subject. And that's 0.71. So those are the ratings we have. When it comes to self-reported rating, we have looked in the lab as well. If we pool all the subject self-ratings together, then we see a pattern that during the stress sessions, we see higher and otherwise lower. But if we look at each individual subjects, some of them, they just don't report stressed at all during the entire lab session. So therefore, I wouldn't expect higher correlation when we look at the correlation of their self-reported rating versus their physiology. So what I would like to propose is that this measure of stress that we obtain from physiology is kind of an independent measure. It has some correlation. It varies in the same direction as that with self-report, but certainly is in no way trying to substitute for self-report. Okay. So where do we stand with the stress modeling? So we have some initial validation with self-report. Now we're applying that to new data that we have collected as part of the Memphis study. And we'll shortly know what kind of numbers we get for that. We also conducted another lab study in Minnesota with 26 new subjects, and what we're going to do is we're going to test our physiological model, which was trained from the previous lab study, to see how well it is able to do with this new study. And then I think the best will be if this measure of stress is useful in predicting a clinical outcome, and we are right now trying to do that with abstinent smokers to see if it helps predict relapse in smokers. And our goal is that we would release this entire source code and the model to the community, so anybody else should be able to try it out. So next, I would briefly talk about the smoking and conversation. So automated assessment of smoking would be very helpful, so that we don't have to fully rely on each subject remembering to report their smoking episodes, especially when they are in the abstinent phase. So we have certain devices that are in the market for, say, Crest Pocket, that can help get smoking topography again if the subjects remember to smoke through that Crest Pocket. But they still can't substitute for automated assessment of smoking. So what we discovered is that the respiration measurements do have a pattern, distinct pattern when somebody is smoking, which is different than during stress or during running or during a conversation. It is possible to identify smoking puffs from respiration if the data is clean enough. And so we collected data from 10 daily smokers, and we can see that we can detect each puff with about 86% accuracy. And I'll shortly say why that's not good enough. So this is the data from the field. You see, if we look visually, we can still identify the puffs, but we are asking an algorithm to be able to identify it, which is pretty a tall order. The other issue is that if we can identify each puff with 86% accuracy, with 13% chance, we are actually misdetecting a regular respiration cycle, and there are 10,000 respiration cycles in a day. So we don't want to be detecting 1,300 of those as smoking puffs. So there is still quite a bit of work to do. So what we are doing right now, we realize, is that if we have an accelerometer or an inertial sensor on the wrist, then we could potentially also capture the motion of taking the cigarette to the mouth. And if we combine that in time synchronized fashion with the breathing data, then we could potentially detect smoking episodes with much higher accuracy. And that's a study we are doing right now to collect the data, but the trick was to have ground truth, and for that purpose we are asking the subjects to use Crest Pocket when they smoke, so that we will have some marking of when they actually smoked and not just depend on them self-reporting. For assessment of conversation from respiration, we can use audio. You can use microphone to assess for conversation, but using microphone has several issues. One is that the battery can drain quickly. The other is that there are privacy issues and so on. So what we notice is that in respiration, there is sufficient information about conversation patterns. So as I was saying, if we are talking, then we tend to take deep breaths, hold it for some time, and then take another deep breath. So that's pretty distinctive during speaking. Even while we are listening in a two-party conversation, we have an urge to speak, and we tend to hold our breath. So we can distinguish speaking, listening, and quiet states, and from that we can construct conversation episodes. So again, some of the numbers you see here are from the data collected carefully in a lab setting, and I don't have any idea how this will work in the field. So for that purpose, we are actually now going to conduct a study where we fit the subjects or pairs of subjects with high quality microphone, and then they wear the respiration as well, and then actually we will get some hopefully gold standard data that we can use to train the system better, and we will know how well it can work in the field. So if I were to summarize the sensing part of it, here is what I would say. It is possible, feasible to obtain continuous assessment of few behaviors in the natural field environment if we can get the subject to wear the sensor, wear them well, and we identify whether they were wearing it well. If they are wearing it well, then have the right methods to clean the data, and then be able to identify the confounding factors and separate them out. And finally, have the right mathematical model or a right algorithm to be able to assess, infer that behavior from that cleaned confounding factor removed data, and knowing that all of these steps are going to be imperfect. So we are going to have inaccuracy in all of this, and that should be accounted for in whatever you build on top of that assessment. Okay? So next I'll talk about future directions. So, the AutoSense platform, our vision was that we have one platform, single platform that can assess for a variety of behaviors. Thus far, we have some initial evidence that we can assess for stress. We can use GPS to assess for place. We can use the respiration sensor for smoking, conversation. We can also use ECG to assess for cocaine usage. We can have an alcohol sensor all built into the same suite. We can also infer stress. We can also infer physical activity. And it's pretty straightforward to integrate an environmental sensor into it as well. So all of this is feasible, and there is several people have shown that you can use the arm movement also to infer eating. So all of this is feasible to have all in the same suite. When this will become reliable, I don't know, but this is all promising. And so if you want to think about interventions that could potentially make use of this data, I think that work could proceed. So ultimately, all of this assessment is useful only if we can use them to help improve health, right? So we can use them in health research, and that I think could start to happen now. Someday, they can also be used to improve the care of the person by sharing them with the healthcare provider. They can also be used in policy formulation. But I think the biggest impact will be if we can use this continuous real-time assessments to initiate, design, develop intervention, and to trigger interventions in real time. So, and as I said, the main challenges are, if we are to accomplish that, can we reduce the burden of sensing itself? Right now, we ask subjects to stick electrodes so that we can get their ECG. Otherwise, we won't have as reliable of a measure of a stress and for drug usage. Right? So can we reduce the burden of sensing? That's one. Second is, can we indeed have a just-in-time intervention that works and that is able to adapt to the person and the situation? So for reducing the burden of sensing, we have a new direction of the project. In this, we're actually using radar sensing methods and compressive radio frequency probes, so that you'll have still the same kind of sensor that can assess the movement of the heart and lungs without having to stick something to your body. So, even today, actually, you can get a room-sized or computer-sized equipment that if you leave at a distance and fix it to the wall, it can monitor your surface movement, so it can potentially get your respiration rate. But our goal is to be able to get the internal movement, movement of the heart, and that too not from a fixed distance or a room-sized equipment, but this size equipment. So, I think we have been able to reduce it to this size. We are able to show that we can obtain movement of the heart, but the next challenge is be able to do that when the device which is doing this assessment itself can move, as it will if we are carrying it in our pocket, and that's what we are doing right now. So, once this project reaches its conclusion, my hope or dream is that then we can ask subjects to carry this, say, in the upper third pocket or in a locket for several years and give it to 100,000 or 1 million subjects and monitor all of this different behavioral and situational factors that I talked about all simultaneously, and then catch many of the complex diseases right in their progression so that we know pre-post, and we can then try to better explain the etymology of some of these complex diseases. The other side benefit of developing this sensor is that it can not only detect the movement of the heart, it can also tell the body composition. So it can tell how much is the fluid in the lungs, and by tracking the change in the fluid over time, it can also help predict an onset of congestion in a congestive heart failure patient. And that's another trial we plan, pilots project whose trial we are planning to do at Ohio State Medical Center over the summer. And a simpler application is that if somebody carries a device like this, our goals actually are a little bit more than just tracking vital signs. We want to, remember I showed you the shape of the respiration curves, right? So we want to capture the curves, we want to capture the beat-to-beat intervals so that we can infer these behaviors, but just capturing the vital signs is much easier. And I hope that if it gets integrated into the smartphone, then we won't be losing people whose respiration or heart stops working while they're in sleep. So those are our goals while in this Easy Sense project. Next, the just-in-time intervention. So for just-in-time intervention, if we can assess, if we can sense the state, we can actually use to intervene. So I'll give you an example. So if suppose we are able to sense that somebody is stressed, you could either prompt an EMA or you can actually trigger an intervention that is able to calm them down. We can actually, if we try, we can anticipate stress, and here is another example for it. So suppose so all of our subjects wore the sensor in the Memphis study and went about their daily life. So we have data of when they are driving, and we do find that when they are driving, they're actually more stressed than they were during the rest of the day. So if we do find, and we have some evidence for it, that the traffic intersections induced more stress than when they were driving regularly, then you could try to come up with a system that just uses the GPS and the map software on the mobile phone and is able to come up with a route of the navigation system that, in addition to the shortest route and the fastest route, is also able to tell you the route that involves less number of traffic lights. And that could hopefully or potentially reduce the stress. So in this case, as you can see, we are not requiring the person to wear the sensor, but able to anticipate that such and such factor they encounter is usually associated with the stress. And if we anticipate that, we can suggest an alternative to the individual. So that will be one example of being able to anticipate an onset of adverse consequence and helping them avoid it. That's now getting closer to intervention. Okay. Another approach, which is what I'm calling just-in-time intervention here, is if we think of an addictive behavior. So say for smoking. So even if we have an automated way to detect smoking, and we detected the person already smoked, as many of you know, if they are in the abstinent period, they smoked once, they're probably gone to full relapse. So the trick is to be able to catch them before they take their first puff. So for that, we have to anticipate before they take their first puff, when they may be vulnerable. So one approach to try to develop that is, if we have an automated detection of smoking, we can do a study where we detect each smoking episode, and then, or even in an abstinent population, detect when they lapse, and look at what happens on the rest of the behaviors and context that we are able to monitor on the mobile phone and from the physiology, which is the stress, activity, their location, conversation episode, and so on, or alcohol, and then, develop an intervention that is able to identify those fingerprints of the environment from sensor data and then use that to intervene and break their urge. There are several challenges in there. Automated detection of smoking itself is not easy. Developing the right fingerprint that works for each individual specific to the situation itself is not easy, but this is a direction which probably is worth pursuing. So in summary, if we can have a low burden sensing, it can help enable the next giant leap in improving the health, especially behavioral health. But validating any of these new measures in the field environment and knowing how well they would work in a field environment itself is quite challenging. But it's a challenge worth taking, in my opinion. And I do believe that just-in-time intervention may become feasible via mobile health. It is a possibility, but it requires quite a bit of work. Certainly it requires reliable assessment of health status, behaviors, and context that works reliably in the field. The biggest gain could come from finding the right moment to intervene. What is the right moment when the person is most vulnerable or most receptive to intervention? And I think that can bear quite a bit of fruit. And if all of this works, I believe there is a need for a lot of theories as well. The behavioral intervention theories that we have thus far, do we already have all the theories that account for finding the right moment for intervention? Or do we need to revisit some of those theories? Do we need to redevelop some of the behavioral intervention theories that can help design interventions that could have this kind of nature? The other is, if we have those kinds of interventions that are going to be so adaptive, do we have the right methodology to evaluate them? And so those are the two thoughts that I would like to leave you with. So with that, I would conclude the talk and thank the numerous people, our generous collaborators, whose work is what I'm presenting today. Of course, there are several students and postdocs who have done all the real work. And if you are interested in reading further, there are several articles that you can browse through. Thank you a lot for your attention.
We are at 10, but I'd like to, since we had the audio problems beginning, I'd like to just take a couple of questions here take an opportunity to have a couple of questions from the audience.
Yes.
I want to ask a question about something you didn't really touch on, but knowing that you chaired this NIH workshop, I'm curious what your thoughts are on how we know that all this technology leads to health improvement without an RCT or avoiding an RCT and without bias.
Yeah, so I think it is a challenge.
Can you, if that microphone is not, can you just
Yeah, so the question was, of all this technology, how could we evaluate them without an RCT or avoiding an RCT? I'm not sure if the question is about avoiding RCT, the question is about, can we reduce the time and effort needed to evaluate, right? If suppose RCT could be done in much less time and much less effort, we could do that as well. So there are several ways that this technology itself can help by collecting the data, by making it possible to collect the data at large scale at short notice. And that could potentially help. We certainly need newer methodologies that can accommodate change in the intervention or adaptation in the intervention or adaptation in the technology itself. And David has been working on some of those methods for evaluation. There is an article that came out of that workshop, and that will appear in the American Journal of Preventive Medicine, I think in October or so. So I think that could provide a summary of the thoughts that tries to address exactly this question.
It doesn't work, so I'll just
yes.
Thanks very much for a terrific talk. The technologies are very impressive, and I'm prefacing this. I'm a huge fan of your work, and I think this is all great. But it also seems like we're in the midst of creating another science-to-service gap, and I'm always concerned about adoption of technologies, the training that would be provided, the resources that would be provided to the folks who are in greatest need. So if you're thinking of the greatest health disparities, people with comorbid disorders, people with serious mental illness, people with cognitive impairment have very messy lives, right, as most humans do. How are you integrating the needs of your intended users on a mass scale at the conceptual level?
Okay, so the question is, how are we integrating the technology in the most needy users, right, so that they ultimately are able to use it? Is that a good paraphrase?
The challenge, the conditions, and the environmental challenges. How are we considering that as you're moving forward with the technological innovation?
Right. So what consideration are we taking to make it suitable for use by the most needy? Right. So I think one of the philosophies that we have followed all along is that the technology should pervade. That means it should not require anybody to operate. So the best use of the technology will be if it is wear it or you carry it and forget it. And so making it so convenient to use, and that's what Microsoft did, that's why it became such a big success, was making technology accessible to people who are not the geeks. So it's the same here, and the challenge is even more, is that create a technology such that it doesn't require people to operate it. And that's why I was talking about anticipating the need, being able to handle the intricacies by itself, reducing the burden on the person. So that's one side, making it convenient and such that it doesn't require much to operate it. There is another side to it. If you really want something, that's just my personal opinion, if you really want something to be adopted, you have to solve a problem that's unsolved. So which is not just being better, but that's unsolved. So if suppose we throw all this technology to a primary care provider who is extremely busy and tell them, oh, here is this tremendous amount of data I can give you. And I can give you this stress, by the way, which is 50% accurate or 80% accurate. I can give you this activity which works most of the time, and I can give you this diet. So I tell them that you can get all this information. They'll say, I have so little time to cater to all my subjects. Do you want really me to pour through all this data? They're not going to use it. Okay? So the trick is, what is it that they can't do today that we can solve so that they would come to you, yes, this is something we need. And that one example would be tracking the congestion in CHF patients. So at this point, even the nation's busiest CHF surgeon would like to be able to involve with this, because there is no way that they can do this without such a non-invasive technology. And so it is extremely promising. So those are two directions. One is to make them extremely convenient, user-friendly, so that it doesn't require much to use it. The other is to address a problem that doesn't have a solution today.
One of the great applications I can see for this, particularly in rural areas, is increasing compliance of children to asthma plans. Have you done any work around respiratory work in asthma?
So the question was, have we done any work in, applied this respiration measurement to asthma population? That's a great area that we have not yet had time to look into.
I think we're a little over, so thank you very much for a fantastic talk. And you'll be around for a little bit at the break if people want to continue to have questions. Just before we break, if you can hold on for just a second, I think Lee has a couple of announcements, and then we'll go to our break.
Thank you so much. All right, thank you for a great start to the second day. So a couple of quick announcements for my Australian colleagues. It just passed 1 a.m. I just wanted to make that clear. Reminder about the throwdown. If you're on a throwdown team and you haven't gotten with your team yet, you're behind. So try to get with your teammates maybe during this break, during lunch. Find a time to connect and start thinking. You want to win. I know. If you haven't set up your posters, I think there are some spots still that were open. It looked like some of the posters hadn't gone up, so please go ahead and put your posters up. We're going to have snacks, coffee until 10:30, and lunch will be provided, so that's in hopes to kind of keep you all here, and we're going to have our poster session, and I think the demo as well, posters at that time. And the final thing was, we had a really nice turnout this morning for our membership meeting. If you weren't able to make it but are really interested in getting involved, please let me or anybody on the board know. I think that's it. Thank you.
It's okay. It's okay. It's technology.
Sure, me too.
Hi, Dr. Kumar. I'm the chair of the Cancer Support Committee. I see about 1 million people with cancer in support programs every week. The screening data. So we've been moving them in online support groups the whole time. I'm thinking about doing this one with the quarters as an idea. Listening to I was thinking about steps along the way. I was thinking about some of the sort of algorithms that could project patients.